Welcome to part 4 of pediatric cardiac disorders. This is going to address carditis. So carditis has been known by many different names: bacterial endocarditis, subacute bacterial endocarditis, and now it's called infective carditis. It's all referring to the same disorder. Carditis develops when some type of a local bacteria invades the cardiac tissue itself. Peripheral emboli can result. Immune complexes are released, thereby causing a vasculitis that is within the heart itself. And the circulating bacteria and the inflammatory cells adhere to and grow in these thrombi that develop. And what then happens is it causes what we call a vegetation. So it's fibrin, bacteria, and inflammation cells all together develop a vegetation. Once it forms, the continuous blood flow through the heart can knock these vegetations out into the peripheral circulation, and it can go to any part of the body, including to the brain, and cause some kind of a stroke. It can also go to the kidneys and be the cause of the acute glomerulonephritis, which you've already learned about. But what we really worry about is a vegetation adhering to one of the heart valves. Because the heart valves are affected, they are not functioning properly, and therefore congestive heart failure can develop. We see carditis in children who have unrepaired congenital heart defects, but they're not the only ones who end up having it. Even children who've had defects repaired can develop a carditis. It's preceded by some type of a viral or a bacterial infection. The fungal carditis is preceded by prolonged hospitalizations, prolonged access to central lines. In a way, we're causing it. The clinical presentation of carditis will be typical signs and symptoms: poor feeding, no appetite, fever, malaise, as in I don't feel good. They may or may not have a cough, and they complain of chest pain. Blood cultures are sent off and they will be positive. And then we end up needing to give IV antibiotics, antivirals, or an antifungal agent, depending on what grew in the culture. And this is going to be for a long period of time. Minimum is 2 weeks, and it can go as long as 8 weeks. If there is a fungal element, it might be 6 months or longer. It's very difficult to get these vegetations to resolve. So of course this child is going to need a central line. What is your responsibility in carditis? Collect the blood cultures and do it well. We don't want to have contaminated sample. It's going to delay treatment. We're going to administer either antibiotics, antifungals, or antiviral agents based on the culture result. Monitor your lab values for any of these treatment agents that may need a peak or trough level. And then in your assessment of the child on shift-by-shift basis, we want to monitor for changes in the baseline of the child. Do they have a new murmur? If they had a murmur when they came in, is the murmur changing? Because as the vegetation increases, the murmurs are going to be more harsh. What are their vital signs, especially their temperature? Monitor the child for a rash and make sure that they are voiding a sufficient quantity. We want to keep these kids at their bedside doing quiet activities so that this heart can rest and we're not increasing the heart rate. Eventually, when it's time for this child to be discharged, they will receive continued antibiotics or antifungals or antivirals at home. So we're going to be teaching the parents how to administer them. We'll also get home health involved so that they can go out to the home, deliver the product, and reiterate our instruction on how to administer these medications. And this ends a lecture on carditis.